Hello, everyone. Parkinson's disease currently affects more than 6 million people worldwide, more than 1.5 million Americans, and its prevalence, like other neurodegenerative diseases, is projected to rise considerably in the next decades. With regard to Parkinson's disease, the pathological processes and loss of dopamine-containing neurons are already advanced at a time when the clinical diagnosis is made, not unlike Alzheimer's disease. And this likely explains why it has proven so difficult to slow disease progression in persons with clinically manifest Parkinson's disease. Against that backdrop, it is established that there is a prodromal period where certain subtle or seemingly unrelated or undetected symptoms and signs may be present before the classical manifestations of the disease becomes apparent, again, similar to Alzheimer's disease. And this prodromal period may span up to 2 decades or more. And now there is serious interest in delaying or even preventing the onset of clinically manifest Parkinson's disease by intervening during that prodromal phase of the disease. So I'm particularly excited today because our speaker is really one of the leading thinkers and researchers in this space, dating back to the 1980s, when he identified several seminal prodromal features of the disease. And over time, he evaluated the impact of certain interventions to prevent the progression of disease in a number of landmark studies. So we couldn't have a better person today to speak to us on the latest advances in predicting and preventing Parkinson's disease. Dr. Matt Stern is a professor emeritus of neurology. He's the director and founder of the Parkinson's Disease and Movement Disorder Center, which is recognized by the National Parkinson Foundation as one of its worldwide centers of excellence, and it is one of the largest and most comprehensive centers of its type in the United States. Matt Stern, in addition to being a fellow on the HU Academy, of which I'm very pleased to say, is also a dear friend and a colleague, and I'm really pleased that he's taken the time to be with us today and share his wealth of knowledge in this space, and he promised me that he'd be provocative. So Matt, take it away, please.
David, thank you very much for that kind introduction, and thank you for inviting me to be part of this really esteemed group of scientists and clinicians. I thought what I would do today, because I realized that I'm not speaking to Parkinson's experts, but I'm speaking to an array and a diverse group that are interested, as we all are at our age, in neurodegenerative diseases and what we can do to mitigate their onset and progression. And so as I tell you this story today, please keep in mind that progress is impossible without change, and those who cannot change their minds cannot change anything. So I'm sure there are a few minds out there today that I'm going to try and change. Now, just by way of introduction, for those of you who aren't familiar with Parkinson's disease per se, it is a slowly progressive disorder of unknown cause. The classic symptoms include tremor, rigidity, muscle rigidity, and slowness of movement, but there are numerous other motor and non-motor symptoms. The clinical presentation is variable. Some patients present with tremor, others present with gait and balance disorders, others present with muscle slowing, but the course is gradually progressive. And key to our talk today is that the pathologic hallmark is the Lewy body, found at autopsy in the pigmented nuclei of the brainstem. Now, this is just a picture of what a Lewy body looks like. And what we've come to learn is that these inclusions are alpha-synuclein inclusions, and that's really the pathologic footprint of Parkinson's disease. We've also come to learn that these inclusions that are created by clumping of the protein alpha-synuclein don't just occur in the brain. And again, this is going to be key to the story that I'm going to try and tell. Now, we've had very, very impressive therapeutics for the clinical symptoms of Parkinson's disease since the advent of levodopa back in the late 60s. And it was thought that this was the first dramatic breakthrough in the treatment of a neurological disorder. And it was, in fact, quite remarkable. But over time, it became clear that patients continued to progress. There were complications of levodopa therapy, and we were clearly on the search and on the hunt for other therapies that could improve symptoms without causing some of the long-term side effects of levodopa. But clearly the major unmet need today and years ago has been the development of therapies that actually modify the course of disease. And I myself have been involved in clinical trials to modify disease since the mid-1980s. We had therapies that looked very promising in the laboratory and that just didn't pan out in clinical trials, and I'll explain why in a moment. We also need objective ways to establish the diagnosis of Parkinson's disease. Certainly, a clinical diagnosis is the definition of the diagnosis today, but it's very imprecise, and it's certainly not a technique for establishing early detection. And of course, we need a better way to measure Parkinson's disease progression. Every clinical trial we've done with therapeutic agents that are aimed at treating the symptoms have been based on rating scales, on subjective scales of motor function, and really have not been based on biomarkers or any measurable rate of progression of a marker or something in the blood or skin or other part of the body that we can actually measure progression. And obviously, as I said, biomarkers are the key for both diagnosis and measuring progression. Now, here are premises that we've come to accept. I think, first of all, it's important to understand that even though the diagnosis of Parkinson's disease is dependent on the presence of tremor and rigidity and bradykinesia, a clinical diagnosis alone is really quite outdated, and it's certainly imprecise and prevents our ability to think in terms of disease prevention. The problem here is that by the time we make a diagnosis of Parkinson's disease, the pathology is already widespread, so interfering with its progression becomes really challenging. Parkinson's disease is a chronic disease that also does not begin on the day we make a clinical diagnosis. And as crazy as this sounds, this is a concept that's relatively novel. I mean, up until 10 or 15 years ago, Parkinson's disease began at the time we made a diagnosis. Clearly now we know that's just not the case. We also understand that significant advances in the treatment of neurodegenerative diseases like Parkinson's disease will depend upon the early and preclinical detection of the disease and administering therapies aimed at disease mechanisms at that time. Now, this is just schematically what I'm talking about here. First of all, in the upper left-hand corner, you can see how this looks schematically. By the time we make a clinical diagnosis, neurologic symptoms are already present, but clearly something is happening before that phase, and we call that the prodromal phase of disease. In the upper right-hand of the slide is a picture of what we call the Brock staging system. Brock was a pathologist that collected numerous brains and looked at the brains and determined that the spread of synuclein-related pathology probably started in the dorsal midbrain and in the olfactory bulb and moves rostrally into the cortex and other areas of the brain. And what that might look like in, again, schematically, is that in the prodromal phase, there are probably a lot of things that are going on, including autonomic symptoms, other motor symptoms like constipation, high smell loss, fatigue, and other non-motor symptoms that give us a clue that something's going on in the brains that ultimately could theoretically be used as a screening paradigm. The lower left-hand slide is a slide of a rat with synuclein pathology, and I'll explain this a little bit later. So the world of Parkinson's disease has really changed quite dramatically in the last decade or so. First of all, we now recognize that Parkinson's disease is really a widespread neurologic disease that affects regions throughout the central and autonomic nervous system. In fact, Parkinson's disease may begin well beyond the confines of the brainstem. And I'm going to show you evidence that Parkinson's may, in fact, begin in regions of the brain like the olfactory bulb, cardiac, GI, and even visual symptoms, and that extracerebral manifestations of Parkinson's disease may eventually be used in a screening paradigm. And finally, our criteria for diagnosing Parkinson's disease will change, and we will eventually conceive of treating Parkinson's disease in its pre-manifest or prodromal stage. And this actually is happening now. I mean, we have a meeting in Washington in April with the Michael J. Fox Foundation to begin changing our diagnostic criteria for Parkinson's disease to a biological staging system. And we'll talk a little bit about that in a bit. So the story obviously begins with biomarkers. In Alzheimer's disease, it's amyloid imaging. Why do we need biomarkers for our treatment and diagnosis of Parkinson's disease? Well, number one, we need a biomarker to make an early diagnosis. We need biomarkers for making accurate diagnoses and for following disease progression over time. We want to identify patients in advance who may respond to medication in different ways, so we can select the appropriate medication for that patient. We want to confirm target engagement during the development of certain drugs. We want to be able to measure a response to disease-modifying therapies that go beyond just subjective rating scales. In Alzheimer's disease, for example, there have been several drugs that have been approved because of their effect on amyloid imaging without significant effects on clinical outcomes. Controversial, but it does open the door for considering ways of modifying biomarkers in Parkinson's disease to begin to conceive of slowing progression or even slowing the onset of disease. And finally, enriching populations for clinical trials. And again, we'll show the evidence that we can do this and better understand the mechanism of disease. And now the first most obvious biomarker to search for is genetics. Are there genes that can be markers of disease? And we do know that there are several genes that cause Parkinson's disease. For example, autosomal dominant disorders include synuclein-related Parkinson's disease, LRRK2-related Parkinson's disease. There are numerous autosomal recessive diseases that can cause Parkinson-like disorders. And there are other genes that can increase the risk of Parkinson's disease. So obviously we want to look for genetic risk genes as well. Understanding what these genes do in Parkinson disorders can help us search for mechanisms of disease and allow us to think about targeted therapies. So pre-physiologic phase, genetic risk can be identified obviously very early in life. David mentioned biological fluids, and I'm not going to talk a lot about proteomics and metabolomics or RNA and microRNA levels, but suffice it to say that this is an area rich in investigation to try to come up with blood or biologic fluid signals that indicate that a Parkinson disorder is developing. What I'm particularly interested in, and what has really defined our research initiative at Penn for the last 10 or 15 years, are the early non-motor symptoms of Parkinson's disease. These include symptoms like smell loss, REM sleep behavior disorder, cardiac sympathetic denervation, which might be manifest by diminished heart rate variability, which we see in patients with Parkinson's disease, constipation, visual changes, depression, all non-motor features that occur in Parkinson's disease well before the onset of neurologic symptoms. And the question we asked ourselves is, well, can some combination of these factors confirm a sufficient risk of Parkinson's disease to warrant treatment with either neuroprotective agents or disease-modifying therapies? And this is a little bit of a scheme of what this might look like. If we look at the 10 years prior to the onset of clinical symptoms, we call this the prodromal phase. And in that phase, we know there are symptoms like REM sleep behavior disorder, there's autonomic dysfunction, we know there's smell loss, there's a high incidence of depression, somnolence, slight motor signs, and even imaging abnormalities. In the preclinical phase, even before this occurs, this is where we're looking for blood and CSF and tissue biomarkers. And then, of course, we already talked about the early life risk phases where we're looking primarily for genetic markers. And you'll see the word environment here. And this is intriguing. Are there environmental factors that weigh in here? And I'm going to save this for the very end. Now, a little bit of a complicated slide, but an interesting one. This is a primary care registry in the UK that my colleague Annette Schrag studied. And what she was interested in is in these well-recorded histories of patients. Were patients who had the onset of symptoms like fatigue, constipation, dizziness, more or less likely to develop Parkinson's disease later in life? And lo and behold, in this registry study, patients who had these symptoms were much more likely to develop Parkinson's disease over time. And the implication here, indirect though it is is that patients who have these premorbid symptoms like fatigue and dizziness and constipation, depression, anxiety, insomnia, all may be premorbid symptoms of Parkinson's disease occurring well before the onset of neurologic symptoms. And it was based on that collection of information that we began to think that we need to redefine what Parkinson's disease is. Up until a decade ago, when we put this together, Parkinson's disease was felt to be a clinical diagnosis, as we mentioned, that you needed a certain clinical parameter to be accepted as a diagnosis. And we began to think that the failure of all of our disease-modifying clinical trials and the presence of prodromal symptoms really necessitated a redefinition of the disease. And what we proposed was that we look at Parkinson's disease as a multi-phase disease, that phase 1 would be referred to as preclinical Parkinson's disease, where we assumed pathology to be present, and that this would be supported by molecular or imaging biomarkers, but there were no clinical signs and symptoms of disease yet. Phase 2, we refer to as premotor Parkinson's disease, where you might find the presence of subtle motor signs, perhaps a slight tremor or a little bit of rigidity, but no effect on quality of life, and due to pathology outside the substantia nigra, where the root of clinical symptoms probably originates from. And phase 3 is what we call motor Parkinson's disease. This is where pathology involves the substantia nigra, leading to nigrostriatal dopamine deficiency sufficient to cause the motor manifestations that had become the footprint of a clinical diagnosis. Now, if you think about this, all of our clinical trials up until this point were based on phase 3 Parkinson's disease. And despite the fact that so many of these therapies look so promising in the laboratory for interfering with the disease process, it's no wonder that we came up empty in terms of the results of these clinical trials of disease modification, because we were starting therapies in phase 3. And we thought at the time that, well, these are patients with very early disease. That's the time you want to intervene. But we didn't realize at the time that even phase 3 disease, there's pretty widespread pathology, and the chances of actually making an impact or a dent on disease progression is probably quite small. And we began to think that we need to intervene here at phase 2 and phase 1 to really have a profound clinical effect. And the last decade of research has really focused on prodromal Parkinson's disease, and it's seen a dramatic expansion in the number of prodromal markers of the disease. We started with a few like hyposmia. We now have probably 16 or 20 markers and a number of prospective studies looking at single markers of the disease. So much of our clinical trial or our in Parkinson's disease have now focused on these cohorts of following progression of patients with preclinical Parkinson's disease to get a better handle on what happens during this premorbid phase of disease. And this is just a listing of a number of these long-term follow-up studies of normal individuals in the pre-diagnostic phase. And I'm going to tell you about one of the ones that we started. We were one of the first to start looking at this carefully, and in our study that we refer to as PARS. And what we did here is we started with, well, first let me just tell you the aims and designs of these cohorts. Obviously, to identify the risk and prodromal markers more carefully, to define the sensitivity and specificity and predictive value of these markers to see whether we could use any of them in a long-term clinical trial. We wanted to define progression markers in the prodromal phase and the time to conversion to Parkinson's disease. And this would enable us to plan clinical trials of Parkinson's disease prevention, or at least delay the onset and progression of disease. Now, let's start with smell loss again, because this is something we observed at Penn in the 80s. And to summarize, significant loss of odor identification occurs early in the Parkinson's disease process. It's not characteristic of many Parkinsonian syndromes, such as MPTP Parkinsonism and essential tremor. We think that the olfactory bulb may be a very early pathologic target. Now, unfortunately, it's not sensitive or specific enough to be a unique predictor by itself because it occurs in other neurodegenerative diseases. It occurs in others in other circumstances as well. But we know that 90% of patients with Parkinson's disease have hyposmia. And interestingly, about 3/4 of them are really unaware that they have impaired smell. They can still taste, it seems. And we also know that it can be detected at least 4 years prior to the formal assessment of that renders them Parkinsonian. And this was the University of Smell Identification test that was developed at the University of Pennsylvania by Dick Doty and colleagues. It's a very simple test. It can be done at home. We can send these out to patients. And this is what we used in the PARS study. And if you look at a population of Parkinson's disease patients, they can be easily differentiated on the basis of their ability to identify odors. Here's Parkinson's disease patient. This is a 40-item scratch and sniff test. And the patients with Parkinson's disease are all much lower in their ability to identify odors than normal patients. So what we suggested was that what if we were to send out thousands of olfactory identification, the UPSIT, the University of Pennsylvania test, and try to identify a cohort of normal hyposmic individuals and normosmic individuals and submit them to dopamine imaging. This is a DAT scan that binds to the dopamine transporter. And in Parkinson's disease, it can clearly be seen to be differentiated from patients who have normal imaging, beta-CIT imaging here. And so we wanted to take a cohort here and follow these patients over time. And what we ended up doing was we sent out about 10,000 surveys from first-degree relatives of Parkinson's disease patients, and we actually got about 5,000 back of filled out UPSITs. That's the smell identification test. And of those, we identified 669 individuals that were hyposmic. Again, remember, these are all normal individuals. They do not have Parkinson's disease. And so we had developed a cohort of hyposmic individuals and normosmic individuals, around 200 that were hyposmic and about 100 that were normosmic. And we followed them clinically over time. We collected spinal fluid. We did beta-CIT imaging and followed them over time. And what we ended up having was, these are the normosmics, 100 of those, 200 hyposmics. And this is the results of their DAT scan. Over 80% binding is normal, 65 to 80% is intermediate, and less than 65% binding is considered abnormal and considered to be predictive of the evolution, perhaps, of Parkinson's disease. And of our normosmic individuals, we only had one patient who fell into that group. But of the hyposmics, we had 11% that fell into that group, and another 17% that fell into the intermediate group. And we followed those patients over time for phenoconversion. And look what we found. This is not actually year 6, year 5, about 60% of those individuals had converted to Parkinson's disease. So if you are hyposmic and you have a DAT deficit in the less than 65% range, you have a 2/3 chance of converting to Parkinson's disease within 5 years. And this is fairly dramatic. I mean, that we were able to predict years in advance which of these patients were going to develop Parkinson's disease. And we published this a couple of years ago in Movement Disorders. And essentially, this is what we showed, that patients who were DAT deficit less than 65% at baseline were much more likely to go on and develop clinical Parkinson's disease than those hyposmic individuals that had normal imaging at baseline. So what did we conclude from these observations? Well, we demonstrated the potential to identify individuals at high risk for Parkinson's disease through a staged screening paradigm, starting with hyposmia and then moving on to dopamine imaging. Our long-term follow-up of those individuals showed a sequential progression from hyposmia to dopaminergic deficit to clinical impairment consistent with the staging system that Brock developed. That is to say, starting in the dorsal motor nucleus and the olfactory bulb, and spreading rostrally to the cortex. And interestingly, the observed rates of biomarker and clinical progression in our study and other cohorts suggest that it's now feasible to test therapeutics in the prodromal phase of disease. And this is the most important point here, is that we now are on the threshold of developing clinical trials to test targeted therapies at the stage of disease where neurologic symptoms do not yet exist. Now, what about another non-motor symptom, REM sleep behavior disorder? And for those of you who don't know, the definition of REM sleep behavior disorder, this is a burst of motor activity during sleep. It can be violent and injurious, and it's thought to be dream enactment behavior associated with REM sleep without atonia. Often this is a complaint of a bed partner, that their bed partner is acting out, flailing around at night, and this often can be injurious, and it's very disabling to patients. And if one looks at the development of neurodegenerative disease in idiopathic REM sleep behavior disorder, again, these are individuals who have this sleep disorder but have nothing else, do not have any neurologic symptoms. In this collection of 89 patients, dementia occurred in 21 of them, mostly suspected of having dementia with Lewy bodies. 17 developed Parkinson's disease, 3 developed multisystem atrophy. All 3 of these disorders, the pathologic hallmark of these is synuclein inclusions or Lewy bodies. So in idiopathic REM sleep behavior disorder may be an early manifestation of a Lewy body disorder. And there are case reports of patients with REM sleep behavior disorder who die without neurologic symptoms during life, who have synuclein pathology at autopsy. And that beckons the question, is REM sleep behavior disorder really premotor or pre-manifest Parkinson's disease? And interestingly, this disorder can precede the onset of these Lewy body diseases by many years, that upwards of 60% of patients who have REM sleep behavior disorder go on to develop Parkinsonian disorders. And in olfactory dysfunction or smell loss is common in idiopathic REM sleep behavior disorder without Parkinsonism. So it's clear that we're now looking at REM sleep behavior disorder as a way to enrich a premorbid population of patients for clinical trials. And if one looks at cardiac and dopamine imaging in REM sleep behavior disorder, let's just start with, this is what a control looks like, dopamine transporter imaging. This is what a patient with Parkinson's disease looks like. And here's a patient with REM sleep behavior disorder who doesn't have any neurologic symptoms, but has dopamine transporter binding that's intermediate between a control and a patient. Again, supporting the notion that REM sleep behavior disorder is really a premorbid Parkinsonian syndrome. Even cardiac imaging is abnormal in Lewy body disease. This is MIBG, which binds to the presynaptic noradrenergic receptor. Here's a control. This is what it looks like. You see binding here. Here's a patient with REM sleep behavior disorder. And here's a patient with Parkinson's disease where there's really very limited binding. And this is just how MIBG works in the heart. It binds to the presynaptic noradrenergic neuron. And if there's an abnormality here, then the binding will not take place and you'll get that kind of an image. What about constipation and PD risk? Well, the Honolulu aging study followed normal individuals for many, many years and found that there was a 2.5 to 4.5-fold increase in risk for developing Parkinson's disease over 24 years of follow-up, and that there was a negative association between bowel movement frequency in life and the presence of incidental Lewy bodies at post-mortem. And if you look at synuclein staining in the colon, here's a patient with Parkinson's disease and controlled by patients with Crohn's disease and controls. There's clearly synuclein staining here. And the question is, well, how did it get here? So just to summarize at this point, if extracerebral symptoms predate the motor symptoms in Parkinson's disease, is it possible that pathology can actually begin in the GI tract, for example, or the olfactory system and spread caudally into the brain? And there's some really tantalizing evidence that that might be the case. Here are two large registry studies, one from Denmark and one from Sweden, looking at the effect of a vagotomy and subsequent risk of Parkinson's disease. Remember, vagotomy has been a treatment for peptic ulcer disease. And one can do a truncal vagotomy or a selective vagotomy. And in this case, comparing truncal vagotomy to superselective vagotomy, patients with truncal vagotomies were less likely to develop Parkinson's disease than those were the superselective vagotomy, implying that if you remove the vagus nerve, you don't have a way for synuclein pathology to get from the GI tract to the brain. And interesting, and this is what it looks like schematically. This was the Swedish-based study. Here's truncal vagotomy here, and these are truncal vagotomy here, and these are the patient's case controls. And the patients who had a truncal vagotomy were less likely to develop Parkinson's disease 20 to 30 years after surgery. So interesting, it's indirect evidence, but it certainly suggests that by removing that source of synuclein, perhaps we are reducing the incidence of Parkinson's disease, implying that the disease actually spreads from the GI tract. Now, when we talk about spread, it's really an intriguing question. I mean, is it possible that synuclein pathology actually does spread, kind of like prion disease? Is it possibly that synuclein itself is a transmissible protein? And there's accumulating evidence that, in fact, synuclein may spread from cell to cell, just like prions. And this was a study done by my colleagues in the Center for Neurodegenerative Disease at Penn, Kelvin Luck and John Trojanowski and Virginia Lee. And they looked to see whether they could take pathologic alpha-synuclein and transmit it in non-transgenic mice. An intriguing question. This article was published in Science now 10 years ago. And what they did was they took synthetic alpha-synuclein fibrils and showed that they can transmit Lewy pathology in wild-type non-transgenic mice in vivo. And what they did was they took preformed fibrils of wild-type alpha-synuclein and injected into the dorsal striatum of young mice, just one injection. And then mice were examined over time for alpha-synuclein pathology and neurodegeneration, transmitter levels, and motor function. And interestingly, and just this is a complicated slide, but just pay attention to the lower left hand with the little red dots. And you'll see that these are 30 days, 90 days, and 180 days. And by 180 days, the pathology is spread throughout the cortex. And this is from one preformed fibril injection in the striatum. And this is pretty convincing evidence that at least in this model, you're showing transmission of Lewy-type pathology throughout the brain from a single inoculation. And their conclusions were that synthetic fibrils can transmit Lewy pathology in wild-type non-transgenic mice, and that a single inoculation of misfolded synuclein in the striatum can lead to neurodegeneration and the accumulation of pathology in connected brain regions. These changes were associated in these animals with loss of motor function and loss of biochemical markers of dopaminergic integrity. And this model of disease does not rely on overexpression or mutant endogenous alpha-synuclein. And the question is, does progression of Parkinson's disease also occur secondary to cell transmission of pathologic alpha-synuclein species? And this is really an intriguing question that may have tremendous implications on both early detection and targeted-based mechanisms of therapies. Now, if synuclein pathology is widespread, which is the case I've been making here, in Parkinson's disease, shouldn't we be able to measure abnormal synuclein in blood, spinal fluid, or peripheral tissues? Shouldn't abnormal synuclein be a terrific biomarker of disease? And this has been the subject of a tremendous amount of research just in the last 4 to 5 years. And there are deposits of alpha-synuclein that can be measured. And here's a review and meta-analysis that was published several years ago. And what they used was alpha-synuclein immunoreactivity in living specimens to look for binding as a potential biomarker, and found that anti-synuclein antibody had higher specificity than an N-synuclein antibody, and that examination of a skin biopsy using this immunoreactive technique has the best diagnostic accuracy. And the interesting question is, well, can we use a skin biopsy? That seems pretty simple to diagnose Parkinson's disease. And in fact, there is now a commercially available skin biopsy as a diagnostic test for Parkinson's disease. Again, using the argument that the diagnosis of Parkinson's is currently based on clinical criteria, but a novel study has found that the presence of these neuronal deposits of pathologic alpha-synuclein in the brain and the skin distinguishes them from individuals with symptoms of Parkinson's due to the accumulation of another protein like tau. So skin biopsies may have a role in the diagnosis of Parkinson's disease. The problem is that there are limitations of traditional antibody-mediated detection. First of all, there's contamination with alpha-synuclein from the blood. You're not directly detecting the disease-relevant alpha-synuclein species. And so there's a great overlap with normal controls. And that's been a problem with traditional antibody-mediated detection. However, there's a new technique called protein misfolding cyclic amplification. Some of you may have heard of this technique. This enables the ultra-sensitive detection of misfolded alpha-synuclein aggregates. And the way it's done is you incubate samples containing minute amounts of misfolded oligomers. You need a single misfolded oligomer, and you add the monomeric protein to really induce the growing of polymers. You're essentially putting your fluid in this mixture and shaking it up. And and after each cycle, the number of seeds actually increases and becomes measurable. And this was first developed by Soto and colleagues looking at prion disease. Prion disease, remember, is the cause of Kuru and mad cow disease and Creutzfeldt-Jakob disease in humans. And what they showed is that they could detect a single particle of misfolded prion protein, which has led to the detection of prion protein in the blood and urine of symptomatic and pre-symptomatic animals, and in human blood and urine in patients who have Creutzfeldt-Jakob disease. In Parkinson's disease, it's fascinating that using this cyclic amplification technology that detects minute amounts of misfolded oligomers in the spinal fluid correctly identify Parkinson's disease with an overall sensitivity of almost 90% and a specificity of 97%. I mean, that's highly, highly accurate. And this is just another example of looking at using this technique in dementia with Lewy bodies, in Parkinson's disease, finding virtually 100% positivity, looking at this seeding assay for detecting the presence of abnormal synuclein as opposed to controls. Now, what's not been published yet, and this is just another example of skin alpha-synuclein aggregation using the same kind of technology, showing 100% accuracy in dementia with Lewy bodies, 95% in Parkinson's disease, 2/3 of patients with multisystem atrophy. Again, these are synuclein diseases, as opposed to very few with Alzheimer's disease and other neurodegenerative disorders. So this is really, really a highly specific test for Lewy body diseases. And what's not been published, but will be publishing soon, is, you remember I told you about our PARS study, and following patients with hyposmia and abnormal dopamine imaging, 2/3 of them develop Parkinson's disease. Well, we actually collected spinal fluid on those patients, and we've looked at this technique in the spinal fluid of those that went on to develop Parkinson's disease, and virtually all of them were positive for these seeding assay aggregates. So it's very exciting, and it's actually led us to really, for the first time, have concrete material to argue for a biologic staging system of the disease, and to leave our clinical diagnosis in the past. So our summary so far is that the combination of biomarkers, genetics, risk epigenetics, and Mendelian genetics, and the advances in detection of synuclein now allow us to conceive of Parkinson's disease detection before symptoms evolve, and to design clinical trials of impactful disease modification. Now, you might say, well, so what? You can diagnose, you can tell me I'm going to develop Parkinson's disease. Is that enough? I mean, what do you do? So what if I know it 5 years in advance? Well, we went back and asked patients that question. We surveyed a number of patients, and the overwhelming majority of patients asked would have chosen to have their diagnosis 5 to 10 years before symptom onset. And their reasons were career and retirement planning. They might make lifestyle adjustments relatively early, including diet, exercise, and stress reduction. They might participate in a clinical trial if it were available. And perhaps most importantly, many patients with the early symptoms of Parkinson's disease end up in time-consuming and frustrating doctor visits. They go to orthopedists because their shoulder hurts. They go to other doctors because other symptoms that are not quite clear, that are clearly Parkinson's disease, and avoiding costly, time-consuming, and frustrating doctor visits for early vague symptoms. So that was interesting to us. And this was a typical patient response. I would have preferred to get the diagnosis 5 years earlier, so I could have had a head start on researching and developing a program that helped. And you can read this for yourselves, but I think some of this I could have gotten a head start on if I knew it was coming. We similarly asked a number of movement disorder specialists, what would they say? And the overwhelming number of movement disorder specialists that we asked also would want to know that we're destined to develop Parkinson's disease. And their reasons were fairly similar: career, retirement planning, lifestyle adjustments. And many of them would consider starting either an MAO-B inhibitor, possibly other medications like antioxidants or anti-inflammatories, and may participate in a clinical trial. So it was interesting that although the argument by the skeptics was, well, so what if you can make a diagnosis, there's nothing you can do, really doesn't hold water. And certainly advancing the field requires that we do this. So that beckons the question, if we can make a diagnosis of prodromal Parkinson's disease, what is the appropriate course of action? Well, consider the following. Here's our model of where we're often faced with this, and this has actually happened to me. You're giving a talk to a patient group, and after your presentation, a 55-year-old man walks up to you and asks for advice. Tells you that he's perfectly normal, but has been diagnosed with REM sleep behavior disorder after his wife complained for several years about his acting out in his sleep. He's also noticed an inability to smell over the last few years. He's at your talk because he has several relatives with Parkinson's disease. What do you tell him? Well, you have a number of options. You could say that's really interesting, but there's nothing we can do right now, so there's no need to pursue this at this time. You could consider getting a dopamine imaging scan, which will help better determine your risk. You can start taking MAO-B inhibitors and non-steroidal anti-inflammatory agents. You can make some adjustments in your exercise and diet regimen or some combination of the above. Well, the first question, of course, is can medications alter the natural history of Parkinson's disease? And you remember that I told you that for 30 years, we've been doing trials of disease-modifying therapies with limited success, primarily because we're starting these therapies at a point in disease where motor symptoms are present, and we feel the reason many of them have failed is because we're starting them too late. So the skeptics would say that we have not proved it in a clinical trial, but have we really done the right clinical trial? Now, let me show you just one study. This was a study of the MAO-B inhibitor rasagiline in Parkinson's disease. And this was what was called a delayed start trial. And delayed start trials are done to mitigate the observed symptomatic effect of a drug. In other words, if you start an active drug that has symptomatic benefits, those patients are going to get better. But if you have a delayed start group, in other words, you keep a group on placebo, as you'll see here, the dotted orange lines on placebo for 6 months and then convert them to the active drug, if it's purely a symptomatic benefit, then when you convert the placebo to the symptomatic drug, they should catch up to the group started on the active drug from day one. But if there's a protective or disease-modifying effect, then they will never catch up. And at the end of your study period, there should be a difference between those started at day one and those started at 6 months. And this is kind of how this schema looks like. And here are the three hierarchical endpoints. In the first hierarchy, there has to be a superiority of slopes in the placebo-controlled phase. This is the early part of the study. You've got one group on the active drug and you've got one group on placebo. The active drug gets better initially because of the symptomatic benefit, but those slopes should never converge. In hierarchy 2, there should be at the end of the study where every patient is on active drug, there should still be a difference from those started at day 1 and those started at 6 months. And then finally, in hierarchy 3 or C, the slopes in the phase where both patients are getting active drug should never converge if there's a disease modifying effect. Now, in fact, in this particular study, this is exactly what happened in the 0.5 milligram in one of the doses. The other dose, unfortunately, it didn't happen. But in that 0.5 milligram dose, you saw a difference at the end of the study. You saw no inferiority of slopes in either part A or part C. And the critics said, well, why did you see it in just the lower dose, number one? And number two, this difference is really quite small. It was only 2 UPDRS points. So that's not a lot, but it's still, there's still a difference. And this was submitted to the FDA, which of course denied the company from claiming a disease-modifying claim. But some of us were intrigued enough by this because this was, again, a study starting in early patients when pathology is pretty widespread, only started and only followed for 72 weeks. Not a long study, but nevertheless, all of these hierarchical endpoints were met. But again, the skeptics out there said it's not enough, the difference isn't enough, and therefore it was largely faded into the sunset as a disease-modifying therapy. But what if we did this differently? What if we started this drug in the premotor phase of Parkinson's disease, and instead of having a study that was only 72 weeks or so, what if it started a couple of years in this premotor phase when we now can identify patients, and we kept the placebo group for longer? It was not a delayed start trial. Isn't it possible that this magnitude of this difference would have been a lot greater? And I share this as a theoretical possibility, but enough of a possibility, I think, that some of us would feel that if this were us, we might take this drug that doesn't have a lot of side effects and that does have a strong amount of basic science data that supports its use as a potential mechanistic-based protective therapy. But you get the idea that this is where our current clinical trials have to begin if we're really going to talk about modifying the course of disease. Now, do we have meaningful clues that the onset or progression of Parkinson's disease can, in fact, be delayed? And there is some indirect evidence. Take a look at this. This is just interferon therapy for hepatitis C, which can be a risk factor for Parkinson's disease. And again, in a large case control study, patients treated with interferon versus untreated patients had a lower risk of developing Parkinson's disease over many years of having the disease. So indirect evidence that, at least in this population, we're limiting the onset of Parkinson's disease simply from interferon therapy. Furthermore, we talked about this a little bit, but we know that alpha-synuclein pathology is prevalent in the healthy human appendix. And these are just slides showing synuclein staining in the appendix. But look at these studies. This is looking at an appendectomy in a large patient registry, showing a 25% reduction in the incidence of Parkinson's disease upwards of 30 years later in those who had an appendectomy versus controls who didn't. Pretty interesting. And even drugs like Flomax, terazosin, which enhances glycolysis. And one theory about Parkinson's disease is that mitochondrial dysfunction contributes to cell death and pathology. And looking again at a registry of patients on this drug, which is used as an antispasmodic for benign prostatic hypertrophy and hypertension, patients on these drugs, on this drug, had a lower incidence of developing Parkinson's disease in long-term follow-up. So again, these are indirect clues that we already have a technique for interfering with the disease process. What about non-steroidal anti-inflammatory use? Well, in this study, non-steroidal anti-inflammatory use and patients who had the gene LRRK2, which is dominant for Parkinson's disease, had a lower penetrance. There was a lower penetrance in those using regular NSAIDs. And one may wonder whether the anti-inflammatory effects of these drugs has some benefit in those at risk for developing Parkinson's disease. Again, indirect evidence, but when you put it all together, there does seem to be evidence that we can alter the natural history of premorbid Parkinson's disease and perhaps delay its onset. Now, of course, the most promising therapies at this point would be to actually target the pathology directly. And there are a number of strategies to consider doing that with. One is decreasing production with RNA interference, inhibiting aggregation, or promoting degradation of abnormal alpha-synuclein, or enhancing autophagy, enhancing lysosomal degradation, or promoting extracellular degradation. This is just a schema of what these therapies look like. And in fact, these studies are underway. And this was a report last year from the New England Journal of Medicine. This is an anti-synuclein protein in early stage Parkinson's disease. And in fact, there are any number of studies. This slide now is several years old, but it shows any number of studies looking at different ways of dealing with the target, the mechanism of disease, decreasing aggregation, increasing degradation, decreasing extracellular alpha-synuclein, et cetera. Now, the problem is that, again, these are all in patients with early Parkinson's disease because, it's just the technology of having a accepted biomarker and has just not been there yet until very recently. I think we're there now. And so even though all of these interesting studies are ongoing, I'm skeptical that we're going to find one that really hits the home run we're looking for, because again, it's for the same reason that we're testing them in patients who already have widespread pathology. And there are other disease modifying strategies that we're looking at. Without going into these in any great detail, we're looking at a variety of techniques that are really aimed at the underlying disease process. So we have no shortage of therapies aimed at the disease process. And what we really have been lacking is the clinical trial methodology to test these in patients with premorbid disease. But at this point, we're pretty darn close. Now, since many of you that are listening to this are my age and interested in brain health and brain wellness, if you do a Google search on how you can prevent brain degeneration, this is what comes up. Moderate intensity exercise, build muscles up, balance and coordination exercises, cut down on sugar, enjoy a Mediterranean diet, blah, 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 everything that none of us really love to do. But this is what comes up. And interestingly, there have been lifestyle factors that have been studied as potential mitigators of Parkinson's disease. And it does turn out that if one looks at stress, for example, there does seem to be a positive relationship between life stressors and the development of Parkinson's disease. Diet, things like caffeine, vitamin D, a Mediterranean diet, flavonoids, all seem to lower the risk of Parkinson's disease, or at least lower the risk of progressing significantly, or they reduce the rate of progression. And of course, probably the most important one is exercise. Even moderate exercise, don't have to be vigorous, seems to reduce the risk of developing Parkinson's disease. So at the very least, if you knew you were going to get Parkinson's disease, you might pay attention to things like stress, diet, and exercise. And I just want to talk for 1 second about the FDA guidance for accelerated approval of Alzheimer's disease drugs, because in Parkinson's disease, we're really right on the tail of Alzheimer's disease. And remember that there have been a couple of drugs now that have been approved using this accelerated approval of Alzheimer's disease drugs, which essentially is reliant on, number one, having an unmet need, and number two, the effect of the intervention is on a surrogate marker of the disease, in this case, beta amyloid, and not necessarily on clinical characteristics. And that the new Alzheimer's drugs, lecanemab or Leqembi, was approved by the FDA despite concerns, and the approval was based primarily on the reduction in beta amyloid imaging, a biomarker of Alzheimer's disease, with limited effect on clinical outcome measures. And I think this is really important, and I don't want to get into the controversy of whether this is appropriate or not, but I think it's paving a picture that at least in neurodegenerative diseases, we are close to accepting the effects of interventions on acceptable biomarkers. And that's particularly important in diseases like Parkinson's disease and Alzheimer's disease. And imagine if at this point, when you think about going into a doctor's office and getting a prostate antigen or having a colonoscopy, or for a woman having a mammogram or a pap smear, all aimed at early detection of a disease so that an intervention can be begun to alter the natural history of that disease. And I think that's where we've been lacking in Parkinson's and Alzheimer's disease. And the whole focus of our attention now is on catching up to 20th century medicine by having techniques for early detection and early intervention. And I think we're pretty darn close. So what about our patient or our friend that came up to us and asked us about having these premorbid symptoms of Parkinson's disease? Well, I think one appropriate thing to do even today would be to discuss his potential risk and the possibility of a dopamine scan to better assess his risk in combination with genetic testing, given his family history. If the DAT scan is less than 65% of normal, I think we could consider, or at least discussing, the use of MAOB inhibitors, perhaps NSAIDs, and perhaps multivitamins, as well as dietary and lifestyle adjustments that have been associated with a reduced risk of Parkinson's disease. And of course, we'd want to enroll someone like this in a clinical trial if available. There we go. So consider, here we are in the near future of clinical practice. Remember that modern medicine is defined by early detection and prevention, and we can now conceive of a biologic and not just a clinical diagnosis of Parkinson's disease. Impacting the natural history of neurodegenerative diseases depends on intervening much earlier in the disease process. I can't emphasize that enough. The response that we can't do anything about it, so why bother diagnosing it, is counterproductive, likely wrong, and will not help us advance the field. Most patients and doctors query would opt for an earlier diagnosis, and that safe interventions, like some of the ones I mentioned, as well as lifestyle changes, may impact the onset and progression of Parkinson's disease, even now without going through complicated long-term clinical trials. The future will depend upon new therapies aimed at the disease process, and we're at the threshold of clinical trials of preclinical intervention that will define the next generation of therapies. Now, I guess that's an hour, David. I have, there's one other tantalizing few slides that I'd love to show if I have the time.
Well, Matt, how can I possibly deny you that?
Well, let me just, so the reason I put these other slides in is because remember at the very beginning of the talk, I said that I wanted to save the talk about the environment till the very end.
Yeah.
But normally in a discussion like this, you can't leave out environment. And because there have been several talks in this symposium series on environmental toxins, I can't resist just sharing a few slides about the presence of environmental toxins as potentially another potential cause of neurodegenerative diseases. Now, you've seen this slide before, and this has been presented in one of these talks, showing that there are, 85,000 chemicals are registered with the EPA. I just want to acknowledge my colleague, Ray Dorsey, who's done a tremendous amount of work in this area as it relates to Parkinson's disease, and he loaned me these slides, so I'll give him credit. But, let me just give you a few examples. These are obvious. Most lung cancer is clearly man-made. You know that. There are other diseases. Stopping a pandemic deadlier than COVID. Well, what's that? Well, this distinction goes to cardiovascular disease, a pandemic so common it's become invisible and so ingrained in the fabric of modern society it seems natural, but it's not. It doesn't necessarily have to be. And then there are things that are a little less common, like acne, which does seem to be a disease of Western civilization. This was just one study in Papua New Guinea showing that very few subjects had acne compared to Western civilization subjects. So there are diseases that we think may be due to environmental effects. Now, let's just look a little bit, you may criticize me for stretching a little bit here, but it is tantalizing. First of all, Parkinson's disease may begin in the nose. We've made that point pretty clear. Global sulfur dioxide emissions by world regions dramatically increased in the last 50 years. Just look at this increase in the use. Now, this is just one chemical, but it's rampant in the environment. And what about in the gut? Again, the global pesticide production has just dramatically increased over the last 40 or 50 years. And interestingly, this was an exposure in a magazine in October of last year, paraquat. Now, I just want to say one word about paraquat. There was a drug called MPTP that some of you may have heard of. MPTP is the byproduct of contaminated heroin synthesis. When MPTP is injected into drug abusers, now this goes back into the 80s, they came down with acute Parkinsonism. And it turns out that paraquat chemically looks very much like MPTP. And paraquat is rampant. And exposure to paraquat does increase the risk of Parkinson's disease. And again, I don't want to get too political here, but there are files that suggest that the makers of paraquat feared a long time ago the weed killers linked to Parkinson's. And this link is no surprise to us that know the chemical structure of this compound. This is just, numerous studies have linked pesticides to Parkinson's. Paraquat may double the risk of developing Parkinson's disease, and this is just the estimated use of paraquat in agricultural land. This is only 5 or 6 years ago. And if I superimpose the prevalence of Parkinson's disease on this map, you'd probably be shocked to see that it almost mimics this by chance. And I know this is something that Ray Dorsey talks about. But it's just intriguing that this disease is so common and that the use of these chemicals is so widespread when Parkinson's disease was once rare. It was only described in 1817. And, there were plenty of people around, even though everybody says, well, the life expectancy was only 40 or 50 in those days. Yeah, but there were plenty of people around in their 60s and 70s and 80s. And yet Parkinson's disease was once considered rare. But now it's probably the fastest growing brain disease. And why is that? By 2040, we think there'll be, 13, 14 million patients worldwide. So it's becoming a much more common disease. This is paraquat's use in the US. It's more than doubled for all of these food and vegetables. It's doubled in the last, again, 10, 15 years. And again, I don't want to get too political, but despite its known risks, and the companies and the FDA is clearly aware of its risks, and so is the EPA, but it is still permitted to be used today. So just again, to show you that these industry actions, this is no surprise to you. This went on in the cigarette industry for many years. The concept of concealing health risks of smoking, or in this case, applied to other issues like climate change, and certainly for 50 years or so to chemicals and their link to Parkinson's disease. Finally, this is trichloroethylene. This compound is rampant in the environment. It's used in shoe polishes, carpet cleaners, numerous household products. It can contaminate air, groundwater, homes, and it has been linked to Parkinson's disease. And this is just an interesting study with monozygotic twins, looking back at exposure to solvents like TCE, and exposure to TCE in the symptomatic twin was dramatically higher in patients who develop Parkinson's disease than their matched twin. Time lag between exposure and diagnosis of Parkinson's disease, 10 to 40 years. So again, I don't want to take anything away from what we've talked about earlier, but Ray and his colleagues have put a book together called Ending Parkinson's Disease, a prescription for action, based on taking a much more active role in educating the world about the potential dangers of environmental toxins. And whether you believe it or not, and I have my own mixed feelings about it, I have found myself washing my fruits and vegetables much more carefully now than I ever did in the past. Thank you very much.
Well, Matt, listen, I can't thank you enough for this presentation today. It's a whirlwind of a presentation, and it's an exciting area. I'm glad we're at a stage now where we can actually take a proactive approach to patients who are clinically asymptomatic and identify those at risk. And perhaps, as you've alluded to, in addition to lifestyle modification, there may be other opportunities such as MAOB inhibitors, certain supplements that may actually make a difference. And why not start those early rather than waiting a decade or more for the randomized clinical controlled trials to be done, because people who are at risk don't really have the time to wait. So thank you very much, Matt. Look forward to seeing you up here and hosting you in New York when you're here next.